Morning.
Good morning, everyone. Thank you for joining us. My name is Brooke Oliveri. I am the manager of the Long Island Health Collaborative. For those of you who may not know, the Collaborative is a group of 300 plus hospitals, county health departments, and community-based organizations, all working toward improving the health of Long Islanders. So some housekeeping before we get started. Today's program is being recorded. We do have some pre and post-event poll questions for you today, so please answer those when we launch them. And we will have a robust Q&A session at the end of Dr. Spadaro's presentation. So please feel free to put any questions in the chat, and you'll have plenty of time to unmute yourself and ask your questions at the end of the presentation. Many thanks to our sponsor, AARP. We are super excited to have them on board with this Talk with a Doc series. And now I would like to turn it over to Sue Blizzard, an AARP volunteer.
Hi, my name is Sue Blizzard, and I've been volunteering in the ISLIP group for over 9 years. On behalf of AARP, welcome to today's Health Talk with a Doc webinar. We are committed to helping you to stay healthy and stay connected, so we congratulate you for taking the time to learn more about AARP and the Long Island Health Collaborative. AARP is a nonprofit, nonpartisan membership organization for people aged 50 and older. There are 38 million members nationally, approximately 2.5 million in the New York State area, and 500,000 living on Long Island. AARP works to strengthen age-friendly communities and make for happy, healthier residents of all ages. And we advocate for those matters most for people 50 and over and for their families, with a focus on health security, financial stability, and personal fulfillment. So thank you for attending today.
Thank you so much, Sue. And once again, thank you, AARP.
Okay.
So before I introduce our featured speaker today, we do have some pre-event poll questions for you, like I had mentioned. I'm going to launch those now. And if you would, please take a moment to give us some of your feedback on these questions. This helps us to improve our programming and to get a better sense of your impressions coming into this program. And I know some of you have been on our past programs, so if you've already answered, no worries, no need to answer again. But for those of you who are new, we would really very much appreciate your feedback. I'll just give it another maybe 20 seconds here. So.
I'm gonna have lunch now.
Oh. Oh.
Okay, it's been 1 minute and 30 seconds. I see 14 out of 17 of you have participated. Thank you so much for giving us that feedback. And now, oh, sorry, give me one moment here. And now I would like to introduce Dr. Louise Spadaro. She is from Catholic Health St. Francis Hospital and Heart Center. You can see her education and training information here. And she is currently an attending physician in cardiology at St. Francis Hospital since 1989. We are very excited to have her here. And without further ado, I would like to turn it over to Dr. Spadaro.
Thank you, Brooke, and thanks for having me. I have to just say that AARP has always been a great source of information for my patients and for my family as well. So we thank them for sponsoring as well. The talk today is pretty broad: heart disease and high blood pressure. We're going to go through a few background information items, issues, and then talk a little bit about how heart disease and high blood pressure, are really so close together. So the first topic of discussion is, what's heart disease? It's a broad range of illnesses. The heart, pretty fascinating organ, but when you come down to it, it's only basically 5 parts. Your heart muscle, which pumps the blood around the body, your valves, which control the flow of blood in and out of the heart. You have 2 on the right side, 2 on the left side, and they are very important in making sure the blood goes in the right direction and not in the wrong. You have your vessels, you have your coronary arteries, you have, actually, Brooke, can you go one more? Could you advance this slide or no? You can't, right?
Yes.
Okay, so just to give you the visual, so the vessels, which are the coronary arteries, the right coronary main artery, which breaks off into the anterior descending. And then you have your aorta, which is the main vessel of the coming out of the heart. And then there's pulmonary arteries and veins. And those are the depiction there, just graphics. The next part of the heart that's important is the electrical system. So that's what causes your heart to beat. Here's just the valves. And the next slide shows our heart electrical system, which is going to control the heart pulse, so the heartbeat or the pulse. And that's also a very organized system of fibers in the heart that you can't physically see, although the electricians of our field can go and find, and we might have time to talk about that later on. And then the last part, which there's no slide, is the pericardium, which is sort of like the lining around the heart, sort of keeps the heart protected from any of the external sources. So the question is, what is heart disease? You can advance to the next one. It's any area of the heart that can get diseased is heart disease. So we all think about heart disease as just coronary disease and heart attacks, but it's really any area. And they're very often combined as one disease, but it's got many components to it. What we're going to talk about today is mostly focusing on the muscle of the heart and the coronary arteries and the aorta as it pertains to high blood pressure. You can go to the next slide. What's high blood pressure? So it's the definition first of what's blood pressure. It's the systolic, or the top number, which measures the pressure in the aorta when the heart contracts. And then there's the diastolic, or the bottom number, which measures the pressure in the aorta when the heart muscle relaxes. Next slide. Normal would be less than 120 on the top and less than 80 on the bottom. Elevated, or people would say borderline, would be the 120 to 129 on top, less than 80 on the bottom. And then there's stages 1, 2 of high blood pressure where it gradually goes higher. And then the crisis, where we're really in trouble, would be over 180 on top and over 120 on the bottom. Next slide. So why do we have to worry about high blood pressure? We have to worry about it because usually, not like other diseases, there's no symptoms related to it. People may think, oh, I'm dizzy, or I had a headache and my nosebleed, and that is my blood pressure. But honestly, usually we have no symptoms. And so by the time symptoms have occurred, there's already been damage done. And that's why, and some of that damage could be life-threatening. And this is why it's called the silent killer. And the other big issue is it's the major contributor to developing atherosclerosis, which is, we'll talk about in a bit, is really what causes most coronary diseases, heart attacks, strokes, and kidney problems. It increases the risks for aneurysms, which are bulging in the aorta or other vessels, and it could lead to heart failure directly or due to a heart attack. So let's go over a few of those issues. Just briefly, atherosclerosis is the buildup of plaque inside our arteries, composed of many substances, and this is an area of great research now. Obviously, everybody knows cholesterol and fats make part of it, but what we don't appreciate is that inflammation cells, white blood cells, and other inflammatory cells take part in atherosclerosis too, and calcium does too, which is why we take advantage of some of the imaging modalities that could pick up calcium on an X-ray. So this buildup happens inside the vessel, and then once it becomes significant, it's going to block up the artery, but more importantly, that plaque becomes unstable and it starts to crack and become more ugly, really. And blood clots form, and there's a whole cascade of events. And eventually the artery will just not get any blood flow, and a heart attack or stroke or kidney damage can occur. And in addition to that, it can weaken the walls and cause an aneurysm. Next slide. So diagnosing hypertension is pretty simple. And again, early diagnosis and treatment are very critical. We should all be especially vigilant to look for high blood pressure or hypertension if you have a family history. So I always say you come from not a gene pool, sometimes it is a cesspool. And for women who've had a history of preeclampsia and pregnancy, it's known to be a risk factor for the future development of high blood pressure. And it's a simple task, an annual exam with a blood pressure monitor or a home check. Very effective. The automatic blood pressure cuffs are excellent. I do recommend only using the arm cuff because of certain circulation issues that happen to us as we get older. It should be several readings, not just, in the morning or only in the daytime, and you should do both arms. Comfortable seated position, feet on the ground. Very important to make sure you have the correct fitting cuff. If you have big arms or little arms, you really want to make sure you have the right fit for your arm. And if that's questionable, sometimes we'll, as physicians, send patients to use an ambulatory blood pressure monitor where it stays on your arm for a day and it just constantly records your blood pressure. A little cumbersome, but it's sometimes very helpful almost to prove to people that they have high blood pressure. The next slide. There's different, actually, did you skip one? Oh, no. So when you go to the doctor, what you're going to do is you're going to get your blood pressure taken. And then part of that exam would be an EKG. I think part of the exam would be checking for signs that their blood pressure has become problematic. So they'll listen to your carotid arteries, making sure there's no noises in there called bruits, looking for vascular disease. So are your pulses good? Are your heart sounds normal? Do you have a murmur maybe because of high blood pressure? Did you develop an aneurysm? And then you would see the belly might be pulsating. An EKG would be done, and you'd look for evidence that the heart's thickening or that there may have been an arrhythmia. A blood test would be done to check the kidney function, because kidneys can both be the cause of high blood pressure and affected by high blood pressure. Same is true for thyroid disease. You want to make sure that you don't have something wrong with your blood, that you have too many red blood cells, because that could lead to hypertension. And of course, looking for other risk factors for your heart, which would be your sugar and your cholesterol. Not typically as a routine, but maybe a chest x-ray would be done and the heart would be enlarged and they may see an aneurysm, and that might also be a clue that there's an issue with your blood pressure. And more advanced testing would be an echocardiogram, looking for thickening of the heart muscle or a valve problem. And then more and more advanced would be certain stress tests and CAT scans, angiograms, PET scans, a whole lecture unto itself. And sometimes it's done because we don't have we suspect that there may be a problem with the kidneys, and so you might be going for a kidney sonogram or a abdominal aorta sonogram. The next slide. There's two different types of hypertension. Pretty much the majority of people are going to be on the bottom. That's essential hypertension. It's 95% of the cases. I say we essentially don't know why you have it. It develops gradually over years. Here's where your family history and your history of preeclampsia are important. But then there are a rare 5% of the population who have secondary causes. Mostly it's because the kidney may be a problem. Either the artery is kinked or narrowed, or you were born with an abnormal kidney or developed diabetes-related kidney problems or medications such as non-steroidals or certain chemotherapy agents. Very rare. I've only seen 3 in my practice over the 33 years, something called pheochromocytoma, which is an adrenal gland tumor. Obstructive apnea, sleep apnea, which has really become to be understood as a very significant cause of hypertension, arrhythmias, obesity, a variety of heart problems that could cause high blood pressure. Treating it doesn't necessarily mean your problems will go away, but it'll be an important part of the therapy. Your thyroid could be overactive or underactive, and that could precipitate high blood pressure. And then medications like birth control pills, some decongestants, non-steroidal anti-inflammatory meds that can damage the kidney and directly raise the blood pressure. and amphetamines like some of the Adderall and psychiatric drugs. Next slide. The treatment of high blood pressure is very important, and the earlier the detection and earlier the treatment, that's essential. And I really can't emphasize how important lifestyle is. If you're overweight, you have to lose the weight. There's a particular dietary approach to stop hypertension diet, or they call DASH diet. Really common sense ideas, heart healthy in general, more fruit, vegetables, whole grains, low fat dairy products, more fish and poultry, vegetable oils, legumes, nuts, and a low sugar diet. It'll also include a low salt diet, and that's sometimes very confusing for people. Just a ballpark, about a teaspoon of sugar a day, of salt a day, or each serving being less than 140 milligrams. It's really not a lot, and you have to be a good label reader, and then just also use common sense. More hydration, reducing calories to lose weight, like I said before, and limiting alcohol, which can raise the blood pressure. Can't emphasize enough, exercise is very important, and I don't mean everybody needs to be a gym rat, but simple walking routines and light weights, or swimming if you have access to it. I hate that we have to even talk about smoking, but certainly if you're smoking, that's got to stop. And getting more sleep, and like I said, treating sleep apnea. Next slide. All the medication, if you do wind up needing medications, and a majority of patients will, all of them will work. You just really have to find the right recipe, and sometimes it's a little bit of a step approach, and you have to work with your provider to figure out what works best for you. If family members have, high blood pressure and they're on something, that's good to know, because sometimes that's helpful to us to pick the right medication. But everybody's choices has to be dependent upon their own profile and history. You usually have to take these medications forever. It's not like you're cured just because your numbers will come down when you start the medication. You have to keep taking them. Sometimes we can adjust the dose down, but rarely are we able to fully stop them, like sometimes is the case for sugars and diabetics. And you need to go for follow-up. You can't just stop them on your own, because that's pretty dangerous, that you can actually sometimes have a rebound. Next slide. I'm not going to go through all of them, but there's basically these categories of medications: simple water pills, ACE inhibitors that work at the kidney level, both calcium and channel blockers, and then alpha blockers, and then alpha beta blockers, and others, and literally hundreds. And the choice, again, should be individualized to each patient. And we can go over them later if there's any questions. Next slide. Other treatments, natural remedies. I'm not anti-natural remedies, but I do want my patients to always check with me first. They absolutely can be used in conjunction with prescription medications, but none of the evidence is scientific. It's all anecdotal, and some can be actually dangerous. I have found that patients who use garlic and magnesium and take in potassium-rich foods do help help to treat the blood pressure along with the medicine. And then more advanced therapies, which is still kind of experimental, are when they can actually physicians can go in and ablate the nerves at the kidney level, which is where most blood pressure comes from, and treat pretty brittle hypertension, not just for obviously the average patient. Next slide. So this is where the heart disease and hypertension come together. How does that happen? So the first area we'll talk about is the heart arteries and the muscle. So we talked about hypertension and atherosclerosis, and they go hand in hand. The longer your vessels are exposed to high blood pressure, the more atherosclerosis is produced, and then that's going to lead to angina, which is the heart not getting enough blood flow, and it can cause the damage to the heart muscle through a heart attack and cause heart failure. It also could cause arrhythmias, such as ventricular tachycardia, which is life-threatening. At the heart level, having high blood pressure first causes the heart muscle to thicken, just like working out with weights. Your heart's constantly pushing against this high number, and it's going to start to thicken. But over time, that might start to fail and become enlarged. And then another aspect of high blood pressure, which is when the heart function is perfectly normal, but it's very, very stiff, that's called diastolic dysfunction. And that's a particular type of heart failure that's actually a little harder to treat because it's finding the right medication usually, but it can cause a lot of symptoms that mimic heart failure that we know of, but it's a different type. High blood pressure, as we said, affects the circulation. So this is going to cause aneurysms, makes you increased risk of developing an aneurysm, which is a bulging in the aorta, depending upon where it is. It could be obviously life-threatening. Abdominal aortic aneurysms, when they rupture, are about 95% lethal, if not caught early enough. And a very common arrhythmia that comes out of having long-term hypertension is called atrial fibrillation, which is probably present in a good, say, 40 to 50% of the population over the age of 75. It's an irregular heart rhythm where the heart's just basically not contracting and relaxing in a normal fashion. Usually the heart rate's very fast. And the problem with irregular heart rhythms like that is that it could lead to a stroke if blood clots form inside the heart when it's not contracting and emptying correctly. And over a period of time, it could also cause the heart to weaken and become enlarged and develop heart failure. Next slide. Heart hypertension can also affect our valves. They could cause the aortic or the mitral valve, that's what the two on the left, to become weakened and leak. It could elevate the pressure in the lung arteries, and that's a situation called pulmonary hypertension. Just like you have high blood pressure in your arm vessels and your body vessels, you can have it in the lungs, and that can cause problems. We talked about aneurysms, both in the aorta and in the brain, causing intracerebral bleeding. Kidney failure, a very complicated mechanism of how it works, but this is the #1 cause of dialysis, especially in African-American men. Atherosclerosis in other arteries, so it could affect the carotid arteries, which can lead to stroke, maybe, and disease could be treated, but you don't want to have to get there. Inside the brain, causing atherosclerosis can probably be the most cause of dementia or an age-related memory loss. And then from the peripheral vascular disease in our legs and our hands, it can cause cramping when you walk, which is called claudication, and eventually may be severe enough that it could lead to gangrene and potential need for amputation. Next slide. So what's the bottom line? You get good genes. My favorite. Some of us just don't have them. Stay healthy all your life as best you can, and it's never too late to start. Eat well, maintain a good body weight, exercise, and really take advantage of your annual wellness visits. They're really designed to go over you from top to bottom, and they are very effective at picking up things that could be treated early that won't give you problems down the line. And if you are prescribed medications, we as physicians beg our patients, please take them as directed. Don't stop them abruptly, and work with your doc to find the right one for you, or sometimes it's a combination, but it can be done. I have yet to find somebody I haven't found a medication that both is tolerated nicely and will work nicely. And I think that's the last one, right?
Yes, so that concludes Dr. Spadaro's formal presentation. One of the commonalities in all of these presentations has been the promotion of exercise and a healthy lifestyle. And as we all know, walking is one of the easiest ways to get that exercise in. So we just have some tips for walking safely. Always use the sidewalk. If there is no sidewalk, always walk facing traffic. That's actually a New York State law. See and be seen, wear brightly colored clothing, carry a flashlight if you're walking at night. Try to make eye contact with drivers whenever possible. They're more likely to see you. Be sure to cross streets at corners or in crosswalks. Don't jaywalk. Don't text or talk on your cell phone while you're walking. It can be just as distracting as driving using your cell phone, which is of course illegal. And for more information on laws like this, you can visit walksafeli.org. So thank you so much, Dr. Spadaro. We're going to open the floor for some questions now. So please feel free to put those in the chat or unmute yourself and ask those questions.
Hi, Doc. This is Tom.
Hi, Tom.
My question is that of the numbers, the standard set for the blood pressure measurements, why is there not a difference between a 24-year-old person and a 68-year-old person?
Well, on the physician side, when we have somebody who's older and their top number is a little higher, we do definitely say, well, that's probably okay. And then we're more aggressive on the younger side. But by definition, it's across the board. The definition holds for every age group. But yes, we do expect to see, and it depends on, again, the patient themselves. Like you have somebody who has, say, carotid artery disease or maybe a valve disease. Sometimes we allow, quote unquote, or history of stroke or bleeding. Sometimes we allow the top number to be a little higher than the standards based on that particular patient. But when you're talking about coming in for a routine physical and you get screened for blood pressure, you fit those categories no matter what age you are.
Very good. Thank you.
Thank you.
We do have a question in the chat. Is BMI an accurate measure of healthy weight?
It's a good measure of healthy weight, although sometimes there are not exceptions, but you do have to make a little, in medicine, nothing is black and white. You do have variations in body type and, again, underlying health issues. So the BMI is a great way to start the conversation in terms of your ideal body, your health, but it's, there are other factors and other measurements that could be taken that get maybe a little better assessment of your health in terms of your weight, but it's a good first measure.
Okay, great. One other question I see in the chat, someone says, I'm taking Verapamil, sorry for the pronunciation there, for AFib. I get breathless, which could be a side effect of COVID or the medication itself. Is there a way to overcome this breathlessness with exercise?
Good question, and certainly not something that you can give a general answer for, because obviously having atrial fibrillation has its own set of medical issues, and being on a medication such as Verapamil can have that too. So the answer is that exercise can't hurt anyone unless you overdo it orthopedic wise, but exercise can't hurt anyone if they have the okay from their doc. It'll help to strengthen your skeletal muscles so that the heart won't have to, work as hard to do the same amount of activity, but it's not going to cure whatever it is that might be causing the shortness of breath. Obviously, there's much more in that person's health history that needs to be, looked into and discussed, but exercise can't hurt as long as you have the okay by your doc.
Okay, great. One other question I see here, if blood pressure is above 120/80, is it always worrisome or only if it gets way elevated?
So, we've changed, our medical community changed their tune maybe 3-4 years ago. And we used to, in the past, I've been in practice long enough that I remember, oh, it's white coat syndrome, you're anxious, you're just at the doctor, and everything was sort of fluffed off. But we really understand now that it's a continuum. You need to constantly be reevaluated and rechecked. And one number is not a knee jerk to have to go on medication, but it's certainly one elevated number. It's certainly a point where you say, oh, I got to reassess my lifestyle and see where I can improve it, and then have follow-up. And yes, if you are in that borderline stage, you might consider going on a medication, because we know down the line, we're all living long enough, we know down the line that that's going to lead to complications if we don't get it treated early enough. So the answer is yes. It's not worrisome, but it's definitely something that needs to be watched.
Okay, great. Now, I love this next question. In this age of disinformation, what are good, reliable sources for people to use for accurate information?
Really good question, because the bane of my daily existence is when I hear my patients say, well, Google said, or whoever said, Dr. Google. Somebody has a mug, I went to medical school, Google didn't, or something like that. The standard websites like the American Heart Association or AARP actually, and does the Health Collaborative have a website where there's data?
Yes, we do. And we list all of our members, one of which is the American Heart Association and other CPOs like it.
I would say from a cardiac point of view, in good general terms, it's well done, the American Heart Association, and I don't work for them or promote them, but they are the best source of information, really nobody else. Mayo Clinic, actually, I've seen their website is very good on and has information. Cleveland Clinic, all the major institutions that have research and, obviously, amazing scientists working with them are good sources of information.
Great. And of course, presentations like this one are always a great source of information with a medical professional. I see one other question here, and I'm not sure if I'm going to say this correctly. What is pre-eclamp?
Okay.
They even say, sorry, not sure of spelling. I was diagnosed with SVT, had an ablation years ago, and I'm currently on carvedilol. Is there any way to cure this heart electrical problem?
Okay, so two questions. So preeclampsia is probably not our age group. It's you would have a history of preeclampsia for women only during pregnancy, and it's basically when your blood pressure gets very high during the second and third trimester of pregnancy, and you need to be hospitalized and put on bed rest and medications, and then most times emergency delivery, and then medications afterwards until the numbers resolve, and they will resolve. But that history of preeclampsia during pregnancy is important later on in life because it does predict future hypertension as you get older. Same thing is true for diabetes during pregnancy, that it predicts later on in life that you will probably become a diabetic, not probably, but more likely. SVT is one of those electrical parts, one of those diseases that relates to the electrical parts of the heart, and it's an organized arrhythmia where the heart just keeps beating very, very fast because its electricity is going through a certain pathway, and it just keeps looping around. It's called a circus reentry tachycardia is the big word, and that's very commonly treated by ablation, which the person had, and then most times followed by some medications to prevent it from happening, or if it happens, to keep the rate slow. Treatments for that are separate from blood pressure, but the good thing about blood pressure and something like SVT is that one medicine could actually help both. So the answer is whether or not that could be cured, that's the electricians of our field, the electrophysiologists, and ablations are done. Sometimes patients need more than one ablation. Sometimes the ablation has to be very extensive and the person winds up needing a pacemaker to help treat the SVT. But it is something that can be addressed. And as everything in medicine, the advances in that therapy are really coming a long way, and everyday change almost.
Great answer. I don't see any other questions in the chat right now. I actually have a quick question, if that's okay. Both of my parents have AFib, and I'm wondering if that would indicate for me a future with AFib.
So good question. So AFib itself is not a hereditary, there's rare causes of hereditary types of arrhythmias, but atrial fibrillation isn't inherited, but the risk factors that make you more likely to develop atrial fibrillation are. So like the high blood pressure, it's a little nature versus nurture also in terms of your lifestyle and how in the family that you grew up in. I always say you could probably do a lot to try to get away from the risk factors that you inherit by living that healthier lifestyle. So the answer is, if you have those other risk factors for atrial fibrillation, like we said, high blood pressure and other risk factors, then you could also develop atrial fibrillation, but you're not inheriting it per se.
That makes a lot of sense. Thank you.
You're welcome.
If anyone has any other questions, please feel free to put them in the chat. We do just have some post-event poll questions for you here that I'm going to go ahead and launch. Just 5 quick ones to get your feedback on the presentation and your thoughts after the presentation. And while you're doing that, I would just like to say thank you so much to everyone in attendance, to Dr. Spadaro, and of course to AARP. This has been a great series so far, and we're looking forward to the next installments.
Thank you for having me.
While you are answering those questions, I will just say we have a talk with a doc on arthritis and osteoporosis coming up on June 29th, and one about asthma, excuse me, bronchitis and COPD on July 13th. And as you might know, this series is culminating in 2 in-person walking events. As you can see, we're very big on walking here at the Long Island Health Collaborative. One will be at Belmont Lake State Park on August 6th and one at Jones Beach on August 13th. So we would love to see you there.
I have a question.
Sure.
I
If
was
you
just,
have time, Dr. Spadaro.
Yep.
yeah,
You're right.
sometimes my pressure, I'll go to the doctor, will be like 140 over 80s. So sometimes he says, oh, maybe you should start up some medication. But at other times, I'm 103 over 50. So my concern is if you take medication for the higher number, what happens when you're at a lower number?
Yeah, that's a big difficulty in high blood pressure treatment. And that's more what we would consider a more labile hypertension. And I have patients who have swings even larger than that. They're, 90 over 50 at one point, lightheaded and dizziness. And then in hours later, they are 200 over 100 and, we're worried about having problems. It's a real difficulty. And you do have to either, we wind up approaching it in one of 2 ways. Taking a series of blood pressure readings throughout the day for a good couple of days and recording, like keeping a diary and trying to predict, well, when's the time when the pressures are going to be higher? And then if we are concerned enough that we want to treat the high numbers, because we don't want to let the high numbers go untreated, then kind of pick the right medicine and then maybe time the right medicine, time that medicine to be taken when it's most likely the pressure is going to be high. And then, do it that way. If the pressure is in the majority of the day is in the normal range and you just have some mild numbers that are a little higher, then we might just do more lifestyle changes and continued monitoring, because you're right, we don't want you fainting, and it's happened. We've given patients medications and they've, fainted the next day, and that's not a good feeling for anyone, of course. So you do really have to, I say it's like making tomato sauce. I'm Italian, so you have to find the right recipe for some patients, and patients where those light labile swings are where the swings are very labile are very difficult to treat. And that's probably somebody also who should be under the care of either a hypertension specialist, who can fall in the category of a kidney doctor or a cardiologist.
Okay, thank you.
Thank you.
All right. Well, if there are no further questions, I think we will wrap up here. Once again, thank you to everyone in attendance. Thank you to Dr. Spadaro and of course to AARP.
Thank you.
I hope everyone here has a great afternoon.
You too. Thank you.
Thank you.